Hello everybody. Welcome to Number 1 Doctor channel, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like, share our videos, subscribe to our YouTube channel Number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about the pancreas. Acute pancreatitis is seen as a complication of gallstones or in alcoholics. Acute pancreatitis may be edematous, hemorrhagic, or suppurative pancreatic abscess. Late complications include pancreatic pseudocyst and chronic pancreatitis. Acute edematous pancreatitis occurs in the alcoholic or the patient with gallstones. Epigastric and mid-abdominal pain starts after a heavy meal or a bout of alcoholic intake, is constant, radiates straight through to the back, and is accompanied by nausea, vomiting, and after the stomach is empty continued retching. There is tenderness and mild rebound in the upper abdomen. Elevated serum amylase or lipase early on or urinary amylase or lipase after a couple of days are diagnostic, and a key finding to establish the edematous nature is an elevated hematocrit. Resolution usually follows a few days of pancreatic rest NPO, NG suction, IV fluids. Acute hemorrhagic pancreatitis is a much more deadly disease. It starts as the edematous form does, but an early laboratory clue is lower hematocrit. The degree of amylase elevation does not correlate with the severity of the disease. Other findings have been catalogued Ranson's criteria, and they include at the time of presentation elevated WBC count, elevated blood glucose, and low serum calcium. By the next morning, the hematocrit is even lower, the serum calcium remains low in spite of calcium administration. The blood-urea nitrogen bun goes up, and metabolic acidosis and low arterial PO2 eventually are evident. Prognosis at that time is bad, and very intensive supportive therapy is needed in the ICU. A common final pathway for death is the development of multiple pancreatic abscesses. To anticipate them and drain them, if at all possible, daily CT scans are recommended. Carbapenems, quinolones, and metronidazole are known to penetrate infected necrotic pancreas, and they may be used prior to surgical drainage. Pancreatic abscesses come to surgical attention via imaging studies, or when fever and leukocytosis develop about 10 days after the onset of pancreatitis. Ideally percutaneous radiological drainage should be performed. Because that is not always possible, open drainage may be required. Necrosectomy may be the best way to deal with necrotic pancreas. This operation is best done when the dead tissue is well delineated, typically after 4 weeks. The material is scooped out. The procedure may have to be repeated until all the dead matter has been cleared away. Pancreatic pseudocyst can be a late sequela of acute pancreatitis or of pancreatic upper abdominal trauma. In neither case about 6 weeks elapses between the original problem and the discovery of the pseudocyst. There is a collection of pancreatic juice outside the pancreatic ducts, most commonly in the lesser sac, and the pressure symptoms thereof early satiety, vague discomfort, a deep palpable mass. Either CT or sonogram will be diagnostic. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed.